Toward the end of the fourth week, intermediate mesoderm extends along the posterior wall of the abdominal cavity and forms an elevation on the posterior wall of the abdominal cavity called urogenital ridge. The medial ridge is genital ridge. Primordium of the gonads. Let's make a transverse section of the embryo. Ventrally is intraembryonic xylem, which is covered by mesothelium of the lateral mesoderm. In this region, intraembryonic xylem develops into abdominal cavity. The mesothelium develops into peritoneum. The mesothelium proliferates and grows into the underlying mesenchyme, and forming finger-like epithelial cords. These epithelial cords are primary sex cords. These primary sex cords are connected with the surface epithelium. Before the 6th week, there are no primordial germ cells in the genital ridge. Actually, primordial germ cells are visible early in the 3rd to 4th week, derived from endodermal cells in the wall of the yolk sac, near the origin of allantois. During the 6th week, primordial germ cells invade the genital ridge and are cooperated in the primary sex cords. These primordial germ cells migrate along the dorsal mesentery of the primitive gut to the genital ridge. Primordial germ cells have an inductive influence on the development of the gonad into the ovary and the testes. The mesothelium proliferates and forms the primary sex cords. These primary sex cords are connected with the surface epithelium. Before the 7th week, in both male and female embryos, the gonad is identical in appearance and is called indifferent gonad. During the 7th week, the gonads begin sexual determination. If the embryo is genetically male, they carry a Y chromosome. There is a critical sex determination region of the Y chromosome, SRY for short. This gene codes a protein named testis determining factor, which determines testicular differentiation. And the influence of the testis determining factor, the primitive sex cords lose the connection with the surface epithelium. A dense layer of the connective tissue develops. This is tunica abuodynia. The primitive sex cords are renamed as testicular cords. Testicular cords continue to proliferate and penetrate deep into the genital ridge, forming seminiferous tubules. Primordial germ cells settle down in the seminiferous tubules and differentiate into spermatogonia. During puberty, spermatogonia wake up and start to divide over and over again to give rise to sperms, the male gametes. The surface epithelium forms supporting cells, also called Sertoli cells, which secrete anti-Mullerian hormone, inducing the sexual differentiation of genital ducts and external genitalia. These two kinds of cells are packed into the seminiferous tubules, and before puberty, no lumen at all. The seminiferous tubules remain solid until puberty. At puberty, lumen begins to develop, thus forming the actual seminiferous tubules. Toward the hilum, the testicular cords break up into a network of tiny cell strands, later giving rise to the tubules of rete testis. Seminiferous tubules are separated by mesenchyme in genital ridge, which gives rise to interstitial cells, also called Leydig cells. By about the 8th week, Leydig cells begin to produce testosterone, which induce the sexual differentiation of genital ducts and external genitalia. If the embryo is a female embryo has no Y chromosome. Without influence of the testis determining factor produced by the developing testis, the primary sex cords extend into the medulla and degenerate to form the rudimentary rete ovary. At the same time, the surface epithelium of the female gonad continues to proliferate and penetrate into the underlying mesenchyme, forming secondary sex cords, also known as cortical cords. In the 4th month, the distal ends of these cortical cords are split into isolated cell clusters. These cell clusters are called primordial follicles. Inside the primordial follicle, primordial germ cells subsequently develop into oogonia. Surrounding epithelial cells form follicular cells. During the 5th month, oogonia undergo the first meiosis and produce the primary oocyte. But it doesn't complete the first meiosis and stagnates at the preface of the first meiosis until puberty. At puberty, primary oocyte completes the first meiosis and forms the secondary oocyte. Most oogonia degenerate during the first meiosis. About 1 million or so remain. From the origin of the gonad, we can see that they are located in the abdominal cavity. However, after birth, they are located in the scrotum or pelvis. They must descend. Here is the developing gonad, and here is the labial scrotal swelling. There is one band of mesenchyme extending from the caudal pole of the gonad to the internal surface of the labial scrotal swelling. This band of mesenchyme is called gilberniculum. The gilberniculum passes obliquely through the developing anterior abdominal wall at the site of the future inguinal canal. In the middle of the 3rd month, the developing gonad already descends into the pelvis. The female gonad settles down in the pelvis. The cranial part of the remaining gilberniculum becomes the offering ligament, as the caudal part forms the round ligament of uterus. As the male gonad continues to descend towards the scrotum. As the testis descends through the inguinal canal, the peritoneum of the abdominal cavity forms a vaginal process through the inguinal canal. It follows the course of the gilberniculum into the scrotal swelling. And during the 8th to 9th month, the testis has already been in the scrotum. The narrow canal connecting the lumen of the vaginal process with the peritoneal cavity contracts and is obliterated at birth or shortly after birth. If this passageway remains open, intestinal loop may descend into the scrotum, causing congenital inguinal hernia. Congenital hernia is much more common in males, especially in cryptorganism. While attempting to lift a heavy box, the patient noticed a lump in the groin. Generally speaking, 97% of newborns' testes are present in the scrotum before birth. In most of the remainder, descent will be complete during the first 3 months postnatally. However, in less than 1% of infants, one or both testes fail to descend into the scrotum. This condition is called cryptorganism. Cryptorchid testes may be in the abdominal cavity or anywhere along the ural path of the descent of the testes. A deficiency of testosterone production by the fetal testes is an important factor. Surgical treatment is essential, and descended testes fail to produce mature spermatozoa. Men with a history of the cryptorganism have a 20 to 44% increase in risk of the testicular cancer. Well, this is the development of the gonad. Pay attention to the difference between the male gonad and the female gonad. Now, share one case. A 10-year-old boy suffered pain in his left groin while attempting to lift a heavy box. Later, he noticed a lump in his groin. When he told his mother about the lump, she arranged an appointment with the family physician. What is this congenital anomaly called? Explain the embryological basis of this anomaly, and who are easily suffered from this anomaly. Please leave your comments in the discussion area. Thanks for listening.